Hi, my name is Christina Corey, and I am a nursing student at the University of Michigan, class of 2019. I'm going to tell you about a recent patient. Patient is a 52-year-old married Middle Eastern male. He currently works as a pediatric cardiologist in several hospitals in southeast Michigan. The patient's chief complaints when coming to the clinic were severe headaches and rectal bleedings with vein distension in the rectum. His vitals when I took them were heart rate 70, blood pressure 135/85, respiratory rate 20, and temperature 37 degrees Celsius. History of present illness. In 2001, patient was getting occasional headaches every few days that were severe and lasted for several hours. The headaches came in the morning and were pressurized on the back of his head. The patient reported the pain as a 9 out of 10. Taking ibuprofen alleviated the pain, and the patient took it as needed. The headache pain initially interfered with the patient's daily activities before it was under control. In late 2001, the patient knew he had to go to the doctor to know what caused the headaches. In a routine screening, he was diagnosed with hypertension. After the blood pressure was under control with medication, there was no more pain. The patient was given lisinopril to take every day. In 1986, patient began to see blood at the end of his stools and bulging of veins in the rectum. Patient was already diagnosed with irritable bowel syndrome, where he would experience periods of constipation followed by periods of diarrhea. The nature of the severe bowel movements caused straining, and sometimes the bowel movements would last up to an hour. During and after bowel movements, the patient would experience pain in the perineal area and sometimes bleeding. The patient experienced the pain in the area every 2 weeks and the bloody stools once every 2 months. The pain was rated as a 7 out of 10. When the patient was experiencing the pain, it interfered with his daily activities because it hurt to lie down and sit upright. The patient said that eating more fibers helped with less severe bowel movements, and taking suppositories alleviated the pain, but he noted that they were more of a symptomatic relief than a solution to the problem. Hemorrhoids were caused by underlying symptoms of IBS, or irritable bowel syndrome. The patient knew he had hemorrhoids due to the distension of veins in the perineal area and his history of irritable bowel syndrome. Health history. As a child, patient had pneumonia, mumps, varicella, measles, and appendicitis. Patient has allergic rhinitis, astigmatism in the right eye, gastrointestinal acid reflux, lactose intolerance, irritable bowel syndrome, vasovagal dizziness, and hyperlipidemia. Other conditions to report are that he has a deviated septum and is overweight. Patient is up to date on his immunizations. Patient has no food or drug reactions, but has allergic rhinitis, also called hay fever, where he excessively sneezes and gets congestion. Patient was hospitalized once when he was 17 for an appendectomy because of appendicitis. Patient experienced severe pain in the abdomen, fever, nausea, started limping, and had tenderness in the appendix area. After getting an x-ray, he was admitted for the appendectomy. Patient takes several medications. He takes Crestor once a day at night orally for hyperlipidemia, lisinopril once a day orally for hypertension, multivitamins once a day at night orally, and lactate chewable pills orally before eating dairy products. Functional assessment. Patient denies drug and alcohol use but drinks the occasional drink every 2 weeks. He exercises 2 days a week, sleeps 7 hours a night, and snores regularly. He has a mild caffeine intake, about 1 to 2 cups of coffee a day. Patient has no handicaps but uses corrective lenses. Patient has good family dynamics but reports getting occasional family-related stress along with work-related stress. He practices his faith Christianity devoutly. Patient completed medical school in his native country, Syria, and continued his residency and fellowship here in the States. Family history. Patient's paternal grandfather had a sudden death at 58 years old, and his paternal grandmother suffered from hypertension, had hemorrhoids, and died of a stroke at age 64. His maternal grandfather was shot by an extremist ethnic group at age 36, and his maternal grandmother died of a stroke at age 87. His father was obese and suffered from hyperlipidemia, hypertension, diabetes, had hemorrhoids, and died of heart disease at age 38. His mother died of breast cancer at age 63. His brother died of sudden death at age 46, and his other brother is overweight, has hypertension, and hemorrhoids. His sister is overweight and has hemorrhoids. Review of systems. Because of the patient's hypertension, I decided to conduct a review of systems of the cardiovascular system. The patient reports no chest pain or arm or jaw numbness. Patient has no history of heart disease or murmur, but has hypertension as stated previously. Patient reports a perceived change in exertion tolerance and fatigue after he gained a lot of weight. He feels fatigue every day after work and in the morning. Patient can walk 25 blocks without getting distressed, but he noted that he used to be able to go 50 blocks without any problems. Patient has no difficulty lying flat but gets rare palpitations when he feels premature ventricular contractions. He feels these once or twice every few days. Physical examination. The patient's cardiovascular exam revealed no presence of heaves, lifts, or thrills in the 5 key areas of the heart. His chest, including the clavicles and intercostal spaces, are symmetrical and even. There are no obvious deformities, injuries, or bruising on his chest. The point of maximal impulse appears normal and is not laterally displaced. I heard normal cardiac cycles on each cardiac area: aortic, pulmonic, Erb's point, tricuspid, and mitral. No murmur, S3 or S4 sound was heard upon auscultation. Upon inspection of the patient's lower extremities, the color of the skin was uniform. There was a lack of varicose veins and the hair distribution was normal. No edema, tenderness, warmth, lesions, or ulcers were present, and capillary refill was less than 2 seconds on all of the patient's fingers and toes. All peripheral pulses palpated were normal and graded as a 2+ on the aptitude scale. All findings of this assessment were normal. Because of the patient's hemorrhoids, I conducted a review of systems of the gastrointestinal nutrition system. The patient does not get frequent indigestion, but used to get heartburn when eating or drinking coffee late at night. He used to feel heartburns 2 to 3 times per week, especially when he started to gain weight about 20 years ago. As stated previously, the patient experiences bleeding and diarrhea. Patient denies having black stools, heartburn, nausea, or vomiting. His usual bowel pattern is alternating bouts of constipation and diarrhea and experiences pain due to straining and hemorrhoids. Patient has lactose intolerance and feels cramping and flatulence after eating dairy. Patient has no history of colon polyps but had jaundice when he was 10 years old. He had hepatitis A and jaundice was a symptom of it. The patient's abdomen examination revealed a consistent color of the abdomen with the rest of the body, a normal rounded abdomen and an inverted midline umbilicus, free of inflammation or drainage. There was no bulging or masses in the abdomen and no peristalsis was observed. The only scar present was that in the right lower quadrant from the appendix surgery. Normal bowel sounds were heard and they were hyperactive because of the patient's irritable bowel syndrome. No bruit or venous hum was heard upon auscultation of the abdominal aorta or arteries. No tenderness or pain was felt upon light and deep palpation. Patient noted that with bad flatulence, deep palpation might hurt around the umbilicus. During the Iliopsoas obturator and the Bloomberg sign test, no pain was felt. All findings of this examination were normal. Pertinent systems. According to Robert A. Nathan, allergic rhinitis is associated to sleep-disordered breathing, so due to my patient's experience with regular snoring and ongoing congestion, the most prominent symptom of allergic rhinitis, it is important to conduct a respiratory assessment to properly diagnose my patient with this disease. My patient perceives the problem and has self-diagnosed it but has not properly received medication for it. Nathan reports that patients who do not treat it properly may have increasing disorders of attention and behavior. James S. Wolfe et al. Examined the effects of uncorrected astigmatism. He found that uncorrected astigmatism, even in low amounts, causes a significantly decreased vision and, if left uncorrected, could significantly affect patients' independence, quality of life, and well-being. My patient has a diagnosis of astigmatism in his right eye and is feeling symptoms of it in the other eye. If he continues to leave his left eye without giving it proper medical attention, deterioration of it and decrease of quality of life could occur as noted in the article. To give it proper attention, I would perform the HEANT assessment: head, ears, eyes, nose, and throat. Thank you.